Hello, hello. So we will be digging into dermatology topics today because I understand a lot of you all are trying to prepare for board exams. I have highlighted in orange some key terms that might be helpful for quick review, and then also summarized just some basic dermatologic descriptions and special tests if you need those for reference. A couple things just generally speaking before we dig into the topics here would be when thinking about dermatologic presentations, it's helpful not only to think about the lesion itself, but also the distribution. So are hands and feet involved? Are there involvement of skin folds? How are the lesions spreading? Is it top to bottom, central, peripheral? Are there systemic symptoms? And these things can be helpful in coming not only to the right answer on your board, but also looking for distractors in clinic or on tests. So that being said, we'll dig into the first topic, which is acneiform lesions, starting with acne vulgaris here. So we have spectrum of disease ranging from open and closed comedones to nodular cystic acne. The underlying idea here is that there are androgens that increase sebum production, feed bacteria on the skin, and then cause inflammation. So treatment is centered around this disease process. You can use medications that decrease androgens like oral contraceptives or spironolactone. You can use topical or oral antibiotics. You can use low-dose doxycycline for anti-inflammatory effects. And then also topical retinoids or salicylic acid can help reduce the keratinization process that forms the comedones and starts this disease process. A few things to keep in mind with treatment, especially with antibiotics or just antibiotic resistance. If you do use topical or oral antibiotics, you can use benzoyl peroxide wash at the same time. This is bactericidal and can decrease risk of resistance. And then if you are using oral agents, try to not rotate them. Use the same one for flares. And then if you're needing recurrent doses of oral antibiotics, consider something like an oral retinoid. Keeping in mind this is a pregnancy category X, but it can be more curative than some of the other treatments. For rosacea, there's 4 different types of rosacea. There's papular-pustular, there's an erythemic telangiectasic type. The top picture shows the papular-pustule, lower the telangiectasic erythematous type. But you can also have this phymatous presentation like this gentleman's nose, and then ocular presentation. Ocular presentation will be blepharitis, conjunctivis, foreign body sensations. And treatment really centers around the idea that there is inflammation of the skin from some type of trigger. So this could be the Dermadex mite, and the ivermectin treatment targets that, or bacteria, looking at the metronidazole and azelaic acid treatments there. Trigger avoidance is also central. These patients are really sensitive to the sun, so use sunscreen and try to minimize these triggers as much as possible. Folliculitis, so these can be painful or pruritic pustules to deep-seated nodules. If they are in the context of recent hot tub exposure, think Pseudomonas, and this will resolve within 48 hours without treatment. Otherwise, think Staph aureus and treat with topical or oral antibiotics. You can also observe if it's mild. If you have severe recurrent refractory folliculitis, think about immunosuppression. In contrast to a bacterial-driven process, hidradenitis suppurativa is an inflammatory-driven process. So the idea is that you have follicular hyperkeratinization, plugging, follicular ducts expand and then rupture and cause an inflammatory foreign body response. So theoretically, this should be a sterile environment, but this process produces the nodules, scarring, tracts, and from a keyword from board exams, the double comedones. And really, the treatment is trying to decrease inflammation, and that can be local inflammation from heat, friction, and trauma, or it can be more systemic inflammation from things like autoimmune disease, diabetes, obesity. Outside of that, you can treat acute flares with steroid injections or a punch biopsy of the inflamed follicular unit. You don't want to start INDing these, even though it's tempting, because that will introduce bacteria and aggravate that inflammatory process. For more chronic treatment, there are topical oral antibiotics. You can use particular lasers, surgical excisions, immunosuppressants, etc. Moving on to discrimination disorders, erythema multiforme. So this will start off as little papules that then will classically develop this target lesion. It'll be symmetrical on extensor surfaces, and importantly, will start distally and then spread centrally. This is usually from infectious causes and can just be treated with symptomatic management. Keeping in mind eye involvement would warrant ophthalmology referral, and recurrence is common.